Good evening and welcome to this IIC Health Group. This is the first of our meetings. It gives me great pleasure. I want to thank the director, Mr. Srivastav, for convening these policy groups, essentially as a way of doing some research which is new and innovative. And in the health group, this particular group that I have convened, we chose the idea of the emerging crisis of health and social care for older persons, mainly because public health focuses on very many other areas, but this particular area becomes important because it actually brings intersections between the rise of chronic diseases and the life course of aging, and that requires increasingly both health and social care interventions. This particular group, we have 4 papers that we commissioned. The first of the series is by Pallavi, Gupta and Sonali. And we also have a paper by Dr. A.B. Day and Istikar Ali, where we are trying to understand and analyze the Lassie survey. The third is Dr. Tanishta Samantha from Flame University, who is an anthropologist by training, but she titled her paper as Aging, Intimacy and Care Cultures Among Self-Identified Queer, Middle-Aged and Older Persons. And so we are trying to bring in the question of marginalities into this. We are also problematizing the family itself. This notion that the family will be the eternal caregiver is being problematized. And the fourth paper is really looking at by Sri Rupa, Dr. Sri Rupa, who is in the Institute of Social Studies. She is going to be looking at the intersection between gender and aging. So this whole phenomena of feminization of aging. It gives me great pleasure, therefore, to welcome both Pallavi and Sonali. Actually, I met them when I was with the Health Systems Transformation Platform, which is still, and they had already done some very interesting work on home-based care and trying to understand the, if you like, the ecosystem of home-based care, because much of it is in the private sector and much of it is informal. So they were trying to understand the entire architecture of this phenomena of the home-based care, and also bringing in very important questions about workforce, about the training of workforce, about the accreditation of workforce, about certification. So this was a very important area, and I felt that it opens up many, many possibilities. I also want to welcome Dr. Mohan, who is with CanSupport, and it is particularly important. In fact, when Mr. Srivastav asked me who will be your second discussant, and I was talking to Smriti, who's helped us organize this program, I said it has to be someone who also feels passionately and has had experience that CanSupport has done over the years of doing home-based care, for understanding what it means to suffer from a chronic illness, but also to be part of the aging population. So what does it mean? What are the institutional, the structural, the human resource competencies that are required, and also, very importantly, the emotional fallout of caregiving, whether it is the family or of other workers. So without taking too much more time, I welcome you all to this discussion, and may I request Pallavi and Sonali to make their presentation. Thank you.
Thank you, ma'am. Thank you very much for the opportunity. And thank you to IIC for hosting us to have this conversation. So like ma'am mentioned, that in about 2022, Sonali and I did this work on trying to understand home care and as it is evolving in the country. And while doing that, in the beginning, our focus was not on elderly. We were looking at home care services that are being provided by the health sector. And we learned a lot of it is in the private sector. And as we moved on to conducting the study and learning more about it, we realized a major chunk of the users are the people in the older age group. which is when then we sort of looked further into how elderly are coping with the life changes and what are the services available from them. So this presentation that we're doing here in the paper is a culmination of our work that we did at that time on home care as a sector, and then the way we built on it to look at more specifically the elderly population. So which is what we will present here. And during this process, we also had the opportunity to learn from CanSupport's work on providing home care to people in need of palliative care. So all of that experience we'll share with you here, both what we've learned, what the challenges that we see, some of the recommendations that we think can be taken ahead, and would also like to then listen from you what your suggestions and ideas are to take this forward. So we'll start the presentation. Sonali will begin the presentation.
Thank you so much, Pallavi. And thank you so much to IIC for this opportunity, and to Professor Baru for bringing us back here. We don't want to let this topic go since 2022. We have titled our paper Adding Life to Years, Building Care Systems for the Life of Dignity and Quality. At the risk of sounding a little bit academic at this moment, we just want to take you through some numbers, because why there's a need for us to have a conversation or a discussion on this topic. So right now in public health domain, the question is, not the life expectancy, not how longer you want to live, but it is about how well we should age with independence, with dignity, and with that quality of life. We have about 100 million people who are 60 plus right now in India, and in the next 25 years, we see that every fifth person would be 60 plus, which includes all of us as well. This has given to a rise in old age dependency ratio, which increased from 9.5 to 31.5. What it essentially means is we have more 60 plus people, we have lesser number of working age group, and it will put more pressure on the systems or on the families for us to cater on. We also have a rising aging index. It will rise from 8.54 to about 74.5. Currently, it is somewhere in between 40s. This means we are going to have a tapering of a pyramid. There are going to be a lesser number of younger population, and higher going to be 60 plus people for whom we need an age appropriate caregiving. It's not just health caregiving, but as well as the other aspects of caregiving also. We will also be seeing a feminization of aging, where we had more number of female, 1065 per thousand males, which will have again a more chance of vulnerability, marginalization. They would have implications for their health, for their income security, and their care needs. And as we know, nuclear families are rising. We have a shrinking households, urbanization, and migration, which is weakening our traditional family support. So what we understand is that the care need of an older person is not just health, it's functional as well as social. So it's a continuum of functional, social, and the medical care, and it somewhat lies between the three. We can't just be focusing on one. We see that they have about 75% currently are living with the chronic conditions, 23% have multimorbidity, which would mean they currently have one or more conditions with them. And as we see, NCDs are also rising. As we have gendered health risks, like the men are likely to have more cardiovascular or neurological diabetes as a prevalence, but the women are likely to show more prevalence of hypertension, anemia, or depression. While 1/4 have underweight, 1/4 also have overweight. So it's like both the spectrum. We just don't have an overweight condition. We also have like underweight and anemia situation prevalent in this group. With the medical condition, we also see about 24% with functional limitations in their activities of daily living, which would mean the regular needs of bathing, caregiving, washing, they can't do by themselves, as well as they would need their assistance with the instrumental activities. They have to go out or they have to take the medicines. And all of this data, just to give a heads up, is by the LASI study and different data sources, which is published by the Government of India. And then they are also vulnerable to social aspects. About 78% currently in India, they lack the pension cover. They face legal awareness, low legal awareness, they face social isolation, they do face abuse. They also have limited insurance coverage, not just health insurance coverage, but other social pension as well. And all of this condition gets more prevalent when you're coming from the rural part of the India, and it gets more prevalent to the rural older women. With all of this data set in hand, when we were doing our study, what we realized that even as a person, we do prefer to age in our own homes. We do prefer to age in our own familiar environment, no matter how good a institutional facility offers you the support. There are very good social or housing schemes which are there for older persons in India. We see a growing number of private sector, but even then there's an aspect you want to be there where you have spent a lot amount of your time. While intergenerational caregiving within the family has been the mainstay for India, we see that the families are not, for multiple reasons, are able to provide that required care, and they need an external support. With this, we realize that home-based care is an emerging phenomenon in India. That's how the private sector actually came up a lot, because they saw that there is this group, and this group can be catered through this mode. So even during the COVID-19, we saw that home-based care is a method where we could keep our patients to a home and we can provide services there, and not everybody has come to an institution or a hospital facility. So it again gained the momentum. So this home sector is kind of providing a mix of functional support as well as medical support, and some bit of social support they are providing at home through different care providers. However, this concept still in India remains largely urban-centric, and it is unaffordable to many of them. And that's why there's a reason that we need to bridge that gap between the demand group as well as the supply group, which is mostly coming from the private sector. So this is a sort of a summary of that. While we are addressing this group, which is right in front of eyes, we need a continuum or an integration of functional care, social care, as well as the medical care, which answers your which answers your activities of daily living, which also gives you a safe living environment, which also gives you a community or communitization feeling, but answers your medical geriatric care needs as well. So with this background, we developed this paper. The idea of this paper was to understand home-based care within the Indians' health and social care landscape, and also to understand, because we have various ministries which are answering different aspects of, you would see later in the slides, of functional care or social or the medical care. And while we were doing this, we came up a group of care providers which are there, different certifications, skilling they have, and what are the different regulatory mechanism which is governing home-based care in India, and the policy and the implementation challenges we see in ensuring that the care remains accessible, affordable, and of quality. So it's basically a desk review of all the published literature. Primarily, we have referred to a study which as we mentioned, in 2022. It was titled Home Healthcare Emerging Phenomena in India, which mostly started as an answer when we realized like the COVID-19. But while we started reading about or doing more research on the topic, we realized that it's a different group. It's not just the patients at the time they were catering to. There were a lot of different groups they were answering, and that's how we also went up to CanSupport. So that was the first time for us to have an interaction with CanSupport and went to the field with them. What are the providers? What's their day like? The group they cater to. It has also referred to various government reports, mostly LASI or Niti Aayog's papers on this, and the policy documents and guidelines by Ministry of Social Justice and Empowerment, Ministry of Health and Family Welfare, and Ministry of Skill Development and Entrepreneurship. And while we did the central level at large, we did look at some of these states, Kerala being an example, which have done some very good palliative care policy or the programs, and as well as some legislation which has came up through it. So what we realized that the evolving needs of the older persons, they are currently being addressed through one, we have a fragmented government sector which is trying to answer various things, but they are in their own silos, providing care at different levels. Somewhere we need to see how these all can be brought together. And then a private sector which is offering senior care, as well as home-based care for the older persons. So Ministry of Health and Family Welfare is the one key nodal ministry which is delivering primary, secondary, as well as the tertiary care to older persons through their national program for health care of the elderly, mostly through all their public health institutions, at the primary level through their PHCs, through their CHCs, or through their district hospitals. They do have dedicated regional geriatric centers and the National Center for Aging, but mostly it provides the tertiary level caregiving, and they're also involved in some bit of the research on the elderly care, but again it becomes very focused on the medicalized version of the geriatric care. The government program also does outreach camps and home visits to bedridden and homebound older persons. There's another government program by Ministry of Health, which is National Program for the Palliative Care, mostly limited to the bedridden persons and older persons. We have Pradhan Mantri Jan Arogya Yojana. This is a health insurance scheme. It has recently been expanded to the senior persons age 70 and above, and it provides a coverage of 7 lakhs per year, but mostly again it's only for the hospitalization bit. Then we have Ministry of Social Justice and Empowerment. So this is the main nodal ministry, and as you can see on the left, it's their aim. It is written on their website that it's the nodal ministry responsible for ensuring senior citizens live a healthy, happy, empowered, dignified, and the self-reliant life. So with this, they have a yojana, Atal Vayo Abhyudaya Yojana. It aims to improve the welfare of senior citizens. For our focus, we have only referred to 2 of these schemes within this yojana, which is somewhat related to the social part or the funding part related to the home-based care. One is Rashtriya Vayashri Yojana, which provides free assistive devices, but again it is limited to the seniors from the BPL households. And then integrated program for senior citizens, which is sort of funds the geriatric homes or the old age homes or physiotherapy clinics through government institutions or through NGOs or through community organizations. Then we have Ministry of Skill Development and Entrepreneurship. So MSDE, along with Ministry of Social Justice and Empowerment as well as Ministry of Health, they are building a cadre of elder care. So through the Skill India mission, Ministry of Skill Development runs a program. They're trying to build up a geriatric care group as well as home health care groups. We'll be discussing this later in detail. So they are trying to standardize our training modules. They are trying to build up different competency levels within this group as well. So skill development through its National Skill Development Corporation. Further, they have different councils. They are trying to come up with the care providers. Social justice through their National Institute of Social Defense. They are also training a group of geriatric care aides and home care aides. Within the Ministry of Health, they have another wing of NIHFW. They also started with this caregiver providers training program, but somehow it has not been sustainable enough. They had done some batches, but it's currently not being done. So different ministries doing the similar thing, producing a different cadre of groups to address this need. And they mostly go by the name of geriatric care aides, geriatric care assistants, nursing aides, or home health aides, or general duty assistants, all of which provide care at the home as well as at the different institutions as well. Other than these 3 ministries, Ministry of Housing and Urban Affairs also have a role to play. So they have a smart cities mission, and they're trying to make public spaces safer and more accessible to everyone, which also includes senior citizens in their aims and objectives. Not been very successful maybe, but still it is they're trying to build an age-friendly and inclusive social environment. Kochi, however, came up within the member of WHO network as one of a key model example how the cities can be inclusive and age-friendly for all of us. Rural development provides a little bit of social protection, but they also limited to to eligible senior citizens age 60 and above. Mostly it is to the BPL cadre group. They have another Annapurna scheme which is providing free fruit gains. So these are some of the other social aspects other ministries are trying to cover. However, similar common challenges in all of these different programs. There's a low prioritization to the topic. There is underfunding, but as well as there is also poor fund utilization in all of these programs. There's a weak awareness. There are little lesser in-advocate IIC efforts about the program. There are urban disparities. City level initiatives are inconsistently implemented across states and cities. There are 100 smart cities which are to be developed in the smart cities mission, but we see very few examples as an upgraded one. We have social protection gaps, as in many of them gets limited to just the BPL category, and the pension rates may not as well index to the inflation at hand. PMJY, the health insurance of ministry, it covers 70 plus, and then it covers up to 60. However, they just sort of left a 10-year group again between, and they do also face the challenges of delayed reimbursement and low private sector participation. So all of this is what we see the different government programs and the different ministries playing their role, but again in different sectors. And then we'll discuss within the health how home care services for older persons in India are coming up. I welcome Pallavi back.
Thanks, Sonali. So we'll move ahead to the home care aspect of the work that we did and what we learned in there. So in the Indian context, this is how we've defined home care based on the literature that we have, based on the different ministry documents. There was a response from the ministry to the standing committee in the 14th report. So including all of that, we defined home care in a broad way where it covers different kinds of services and by different ministries, different providers. So this is how we've defined it: medical condition, promotive, intensive care, rehabilitation, palliative care, post-hospitalization, including assistance with daily living and diagnostic services, because all of these we found are equally essential for healthy living by the older persons. So what Sonali was referring to about the care workers, I'll just dwell on this for a while. So we have different kinds of care needs, as Sonali mentioned, functional, social, medical, and there are different types of providers that cater to these needs. So there is a family-based group, so which is family and domestic help that families hire. There are community-based initiatives, so community health workers of the government or the private sector, the NGOs. There are the untrained and there are trained providers but not trained for medical services, or non-medical aides who are trained by different councils, which Sonali was referring to in the previous slide. Then there are the medical care, which is by the nursing and allied professionals and the medical professionals, specialists and geriatric care professionals. So this is where we see, so in the first group we have the family members, spouse, children, relatives, and the domestic help. Then we have the community-based volunteers, ASHAs in the government program, and the self-help groups, Mahila Arogya Samitis to provide community-based support. In the trained cadre, which does not necessarily provide medical care, we have these different councils by the different ministries, NISD, NSDC, these councils of the Ministry of Skill Development and Entrepreneurship, and Social Justice and Social Justice and Empowerment. So these are the different cadres. Second one, we see geriatric care aid, assistants, and geriatric care assistants. These are specifically trained for elderly people. At the same time, the others also provide care needs for the elderly, the home health aide, the general duty assistant, nursing assistant. The fourth cadre at the bottom is of domestic aides, and these are actually people who are trained to carry out domestic works, not necessarily care for older persons, but they also sometimes end up providing care for older persons. But some of these cadres are trained to provide basic medical care, and while the fourth cadre is not. Then we have nurses and allied healthcare professionals, including physiotherapists, nutritionists, dietitians, and the medical care by MBBS doctors, geriatric care physicians, palliative care specialists. And the services that are provided include the ADL and IDL related services, community level services in which identification of persons in need, home visits, linking them to the government services. And then the third cadre is the one which provides maximum services, trained to provide the assistance with bathing, feeding, cleaning wounds, some amount of medical care. And then nurses and doctors come in when more specialized medical care is needed. However, a lot of care we found is also provided by the untrained caregivers. While we have trained caregivers, a lot of it is provided by untrained caregivers. And this is families, as we also may have seen in our own families, how people, when we need somebody to care for an older person, how do we arrange? We often ask, it's often by word of mouth. If she is you somebody, I'll ask her, where did you get this person from? And then that is how we find out mostly. And that is what is the most common method even still. Though there are companies, they have their websites, you can go on them and find out. But a lot of people still do it very informally. And a lot of these care arrangements are informal. Going through private companies makes it formal, and that has its own, we can come to those dimensions later in the discussion maybe. But a lot of this happens in the informal sector, because of which regulation becomes really important. But the sector is largely unregulated or very, very loosely regulated. Some of the regulations that are there under which the companies register themselves, they only grant them legality to operate, but does not regulate the quality of services that they provide. And the Clinical Establishments Act, which basically regulates the healthcare organizations or the hospitals, clinics, does not regulate the services provided at home. So there are no standards or regulations as such, and because of which some companies have gone for accreditation by private organizations. So there is one organization which accredited home care organizations, and some 8 companies had been accredited. So this is voluntary, but this is not mandatory. There's no statute around that. So mostly many organizations operate without any legal standing. A lot of nursing bureaus are there which provide care providers, but those are not regulated and formal. So there was an amendment that was brought in 2019, which talks about regulating this home care services to some extent. And in 2022, model draft rules were also brought out, which list the minimum standards for home care organizations, but these were not passed. The 2019 amendment was never passed, and so these model draft rules are there, which the states can refer to if they want to, but they are not binding. So the states are not bound to follow these and develop their own rules. And whereas if the 2019 bill was to be passed, then we would have seen some amount of regulation of this sector, because it said that it will be provided by trained and certified attendants. There would be registered institutions, the costs would be monitored, or at least there would be some guidance on costs, and there would be grades of home care givers, according to which rates will be varying depending on the kind of services that they're providing. But unfortunately, this bill was not passed, so we do not have that regulation in place. Then there were some other bills that have been brought in which do talk of caregiver rights, establishment of national and state elder commissions. So these things have been happening in the back, but none of this has formalized so far. And at the state level, Kerala has brought out this Elderly Commission Act just last year to establish an elderly commission, and it provides guidelines to implement welfare schemes, rehabilitate older persons, and leverage their skill for public benefit, how to upskill the older population and bring them into the economy and in the workforce. So some of the gaps and challenges that we see here are there are inadequate providers those who are there do not have that kind of aptitude which is needed to take care of older persons, because it can also be very draining as a service to provide and round the clock if somebody has to provide. So, and the care services for people with conditions such as dementia, Alzheimer's, Parkinson's are even more scarce, whereas there is literature internationally which shows that if caregivers are upskilled to provide some of these specialized cares, then the care can also be of better quality, and the caregivers also get an avenue for progression and career progression. So there are poor working conditions and safety of providers because they are in somebody else's home, so providing services there. And there are lack of job opportunities and career progression, as we were mentioning. At the same time, it's also the users who are at risk sometimes. Even their safety is at risk. There are instances of theft, there are instances of the caregiver not coming on time or not informing before taking leave, and then that leaves the family high and dry. And the organizations also often take little responsibility for the provider's conduct, because the arrangement is such that we will not be responsible for their conduct while we are providing this provider, but legally they are not bound. So they do the understanding in a way that no liability falls on the organization. And therefore, the affordability of home care services is also a challenge, because a lot of it is in the private sector. So not everybody can afford an 8 hours attendant, or a 12-hour attendant does come really expensive, which is one of the reasons then people go for untrained caregivers and not so much for nurses and not even for trained aides. And under the health insurance, right now it's very, very limited. Some insurance companies are coming up with this package. Sorry, but not all of them have. Sorry. And there are no minimum standards in the absence of regulation, like we were saying. So management of biomedical waste. While some organizations do take back the waste which is generated in offering surgery at home or any wound dressing at home, a lot of it usually goes into the regular household waste. And there is no regulation around it or no guidance around it. Qualification of providers, their job roles, standard treatment protocols, costing. So all these aspects have been left very loose and unmonitored. And neither the service users know what to expect from the provider and neither the providers know. So they both can't hold each other accountable really. So it is a sort of, if someone clicks within the family and there's a good understanding, it can go well. Otherwise, it can also creates a lot of friction. So I'll request Sonali to take on from here.
So I think this is just to summarize what we have been discussing about the home care services for older persons. While we see there are strengths and weaknesses within this sector, strengths being that there's a growing recognition right now because we know that in coming years they are going to form a major proportion of Indian population. We also see a growing private sector which are taking up responsibility to provide this care. There's a growing number of providers who are there in the market. There are institutions who are doing these trainings. There are technology platforms as well. On one click you can just book for a provider on the Max Healthcare website. But there are as well as weaknesses to it. It does remain very Delhi-centric, Bangalore-centric or Bombay-centric. We have very few metropolitan cities in India still have that leverage. Some of these organizations did try to go to tier 2 cities or 3 cities. However, they were not able to sustain their operations there. And this is basis our conversations with many of these private companies. While we are doing a lot of training and all, we still don't have those good quality trained caregivers, including geriatric specialists in India. We have MD geriatric medicine specialization, but it's a very, very limited number, and which will not be able to cater to the demand we have in hand. Also, because there is no standardization, there's no governance, they are paid low wages, which leads to their high attrition, which leads to limited job security. So while you would come here with good intention, a low pay rate will want you to explore some other working avenues. We have weak regulatory mechanisms, as Pallavi just mentioned, which limits its integration within the formal healthcare delivery system. But the sector also has wonderful opportunities because we all want everything at our home. There is a demand for home care services. There is a good young workforce who are equipped to meet the rising need if they are mentored well, and the technological advancements that can further enable that expansion. There is as well threat to it. The quality and the safety of both the users as well as of the provider. The caregivers' exploitation is another example. Sometimes as a user, while I may have hired you to just look for my well-being, I would want you to cook a meal for me as well as for my family members. So it comes with the job, like we all do. And then financial inequities, because it's not covered currently in any of them. It's very loosely covered, like some bits of post-hospitalization at home care, but otherwise it's not, leading to a suboptimal use of home care services in India. So the reason of adding this one international experience slide after the SWOT was this, because while we're reading about it, we realized like many of the countries do have a very well established home care systems in India. It's not just we are now thinking about it, countries have thought about it, they do have a systems in place. Sweden, Japan, South Korea, they faced similar challenges around what we are currently now, India is facing now about the workforce retention or the regulation. And they do realize that they need to have a structured training, they need to have a career path, we need to have accreditation and regulations of our care providers as well as of the organizations. There need to be a standardized care process. Not every company or every organization can't have their own method of providing a home care service at home. And finally, since the sector is there, how can it be formally integrated to our existing healthcare systems? Good examples are from Japan, China and Thailand. They have a very good community-based integrated care models. And India has an advantage because it already has some community-based model care services being delivered through public institutions. And this can simply be added to it. So Japan has a Nagamaya model where the neighborhoods are made so that the people can live in their own homes, in their surroundings and communities while being financially engaged within the system. They are being provided subsidies or support to run a cafe. So you open a cafe around your house, so it gives you a way to earn money to sustain yourself while being there in your known surroundings. So these are just like different examples which can be looked for. Just to go back to Japan's example, I think somewhere in Karnataka, maybe somewhere, some of the self-help groups, they're trying to do a similar examples, but not expanded to the older group, but that can be, covered in this group. So some of the recommendations just from our learnings, from our own understandings, that beyond disease management and functional support, aging does require inclusion. Most importantly, the group needs to be included in the conversation when we are making decisions about them. Companionship, protection from neglect, and the financial security. So one is there needs to have a integration of all these functional, social, and medical care. Different ministries doing different things, but somewhere maybe social justice take the ownership and bring all the ministries together for services. Kerala and Tamil Nadu have a very good currently community-linked public health models. In Veyomitram, they have been trying to provide NCD cares through the community workers who go to the home, provide care. Tamil Nadu have something similar called Makkalai Tedi Maruthuvam, where they provide, it's focused on NCD and palliative care, not just on the older persons, but similar programs can also be maybe brought more. Then we need to have a hybrid model of linking public institutions and private providers, like we do have PMJY, where we are linking public and private institutions. Most importantly, in a home care management, we do need a multidisciplinary team. We need a group of doctors, nurses, physiotherapists, and counselors, care workers, all working together for one patient. It can't be just one care provider for a, I'm sorry for saying patient, but for an older person. From our research, we do feel that a comprehensive policy on home care for older persons, there's a need for it to recognize it as a formal mode of service delivery, if that needs to be incorporated in our formal health systems. We need to have a registry of these providers. We need to have accountability measures that safeguard the interest of both users as well as providers. There need to be a standard HR practices so that they can be sustained. There are career progression or their wages are paid on time. We need to have a transparency for cost, because if you see like one company will send a nurse at your home for 500, another will send a nurse at your home for 850 rupees. So why such a variation? That can be looked into. We need to have permissible radiological investigations at home. There needs to be again a policy decision for it, because we do get x-rays coming at home, we do have ICU setups coming at home, but none of this is legally covered under any of the regulations. They need to manage to how to do a managing emergencies, a process for it, because usually what has happened, even if you are associated with some private organization, at the time of the crisis, it is left to the family's discretion that you decide where you want to take your person to. And there needs to be a grieving redressal mechanism, and of course the biomedical waste management and the insurance coverage. So all of this can be covered into a home care policy. So from all the different providers we see, we feel that there can be a national elder care workforce framework which defines the standards, certification, their career pathways across all the different cadres. We need to recognize home as a place for providing care, as well as for care providers, for it to be legitimized as a formal mode of service delivery. Because currently one of the reasons that insurance companies or the IRDAI say that they are not able to define the norms for it, because it has not been defined. The home care, there is no one standard definition to it. Everybody defines as they want it to be. And there need to be a standardized process to deliver care for different conditions at home. There had to be different protocols when you're delivering palliative care at home, or when you deliver elder care at home, or the intensive care at home. And CanSupport is a very good example to look at it. Maybe ministries can call for stakeholder consultation, form an expert groups. They can develop home care protocols and extension to their standard treatment guidelines, which are there currently within the Clinical Establishment Act, and how it can be systematically integrated within the existing national health programs. We have so many different programs. 2 of them focus on the older group, but there are other programs as well. So how can home-based elder care can be integrated within them and be implemented through their public health institutions? And its integration with the digital health systems. We have Ayushman Bharat digital mission, which maintains a record of providers, private providers, which maintains a record of private hospitals and clinics. So this can also become, these private companies can also become a part of it. And lastly, covering home care services under the health insurance could help in expanding the reach of the services. Thank you so much.
Thank you very much, and I think you've really raised some very, very important questions and considerations in an area which is largely neglected. I'd now request Dr. Mohan to make his points as a discussant. Please, thank you.
The speaker has rightly told that tsunami of old people is chasing us, knocking at our doors, and we are deaf to it. No country in the world, even United States, will be able to handle such a big crowd. You can't admit so many people to hospitals. What I practice is home-based palliative care, that is the answer. Like our ANMs in villages know ORS and zinc for loose motions. Our ANMs have to be trained in palliative care so that we reach everyone who needs it. जब तक हम गांव में नहीं पहुंचेंगे, ये चीज़ें कॉन्फ्रेंस हॉल्स में रह जाएंगी. Of course, I had some experience of working in Singapore. Their model is close to CanSupport model, except that they have modified a little bit. जहाँ पे डॉक्टर की ज़रूरत नहीं है, डॉक्टर नहीं जाता है. जहाँ पे नर्स की ज़रूरत नहीं है, नर्स नहीं जाता है. They have a system where they can hire vehicle like Uber easily, where they need all the three groups. The whole group goes. Once the patient is settled, it is all need based. कहीं नर्स जा रही है, कहीं डॉक्टर जा रहा है, और कहीं सिर्फ काउंसलर या सोशल वर्कर जा रहा है. Since our number is very big, the Prime Minister a number of times has told that he's keen on palliative care. We are working in Punjab at present, training their doctors and nurses. उनके लिए ना एक गवर्नमेंट प्रोग्राम में पूरा करना है, डेटा चला जाए, things like that. I went to certain villages in Punjab where I went to see one patient. I end up seeing 5 patients. As per doctor, हमारे यहाँ कोई bedridden patient नहीं है. जब ANM या वहाँ की जो आंगनवाड़ी से पूछा कि सर 5 patient है साढ़े पिंड विच. So there are hidden patients who are in trouble. We need to reach the unreached also. Same in CanSupport, when you go far away to see a patient, say to Narela in Delhi, we carry some blank cases with us. देखने एक जाएंगे, देख के 3 आएंगे, because going again to that far will be again with clogged Delhi roads will be too tiring and time consuming. Ladies, of course, are stronger than men. It's evidence-based. But many of us, them have to stay alone in old age. And there's a fear of spouse dying in old people. And fear is more in men than in women, which again proves ladies are stronger than men. It is evidence-based. Another issue is multiple morbidity among our old population. There are people who are having diseases from head to toe, skin to bone. They are vulnerable. Our insurance companies provide, very few people are insured, and your premiums tend to go sky high when you age. I've been paying my premium for 30 years and not claimed so far. And my premium has gone sky high. And then many diseases will not be covered and things like that, and home care is not all covered. I think we need to suggest people that To me, I'm in this profession for the last 40 years. To me, it appears probably the home care is the future of medicine. We can't put all people in hospitals. Not even Americans can. Another issue which is emerging is our elders are abused by their own children, servants. There is a law, but parents never go to police for complaint. Most of them suffer in silence. Many rich sons have abandoned their parents on the roadside. It's a reality. Our system in villages used to work where no destitute will be hungry and they'll be looked after. By copying West, I think we have created many problems for our society. I know a family in Ashok Vihar, there are two old people staying, but both of them retired professors. बोलते हैं हमारे लिए दूध लाना और ब्रेड लाना भी एक चैलेंज है सुबह. They don't hire a servant, they're scared they'll kill them. And often we see in CanSupport that hidden patient dies first. If a wife has a cancer, we are worried more about the wife. But sometimes the caregiver dies. Caregiver stress goes unnoticed. And we often think ये तो ठीक ही है. Elderly are even ignored. My age, I'm 74 plus, मुझे लोग पूछेंगे नहीं आपके दर्द है कहीं. And they'll presume with थोड़ा बहुत कमर दर्द तो घुटने दर्द तो होंगे ही. With the result, pain goes untreated or undertreated, which is happening world around. If we have home-based palliative care where A&M is trained, it will reach most of the people. Like training of geriatric workforce, जहाँ मियाँ बीवी दोनों अर्न कर रहे हैं, ऑफिस जाते हैं, 1-1 लाख की सैलरी ड्रॉ करते हैं, उनके लिए 20,000 का केयर गिवर को ट्रेंड अच्छा, इट्स ए थिंग विच विल वर्क. Of course, in cities where people have big salaries, this can definitely work, and we've seen it working. We've been training nursing aides. They are usually the children of the families who lost their parent to that, mainly daughters. Some have found that part-time employment, about 10 to 10,000, 15,000 per month. Pradhan Mantri Arogya Yojana has been given a lot of advertisement, but once you go to hospital and find out this sab line mein lage reh jaoge. If a person of 75 says mujhe hernia ki surgery karani, which is not an urgency, though it's important but not emergent usually, कि सब लाइन में लगे रह जाओगे, अगर आप 1.5 लाख पे करते हो तो कल कर देते हैं और आपको घर भेज देंगे. Geriatricians are very few, but we don't need trained geriatrician for all patients. General doctors can be trained. There is a law protecting elders from their own children. It has been passed, but parents usually never complain. Sometimes neighbors complain. Kerala model is doing very well, but it's not applicable to cities like Delhi. वो कई untrained professional भी काम करते हैं. CanSupport, we don't dare to do that. Whatever you do with the patient has a legal implication. Like we use opioids very often, we even used for geriatric patient. I remember Paschima had a patient who, Kerala lady 80 years old, She had a severe joint pain. At this stage, you can't do surgery. जैसे नॉर्थ इंडिया में कल्चर है ना, दादा पोती रहते हैं, उनके यहाँ दूसरा कस्टम है, नानी 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 उसके उस मैटरनल साइड्स के लोग रहते हैं. We started a small dose of morphine to that patient, 5 milligram twice a day. Next time we met the grandchild of the patient, great grandchild, says, "Doctor, your medicine worked very well. Nani doesn't cry at night now." So that type of care where people are passionate about looking after older people. And believe me, even dying people are living. They make a difference if you manage their pain well. Of course, dropouts among the carers who are paid one will be is an issue because there is no promotion. We will not recognize them as a workforce, but 8वीं 10वीं पास बच्चों को अगर ट्रेन कर दिया जाए तो जॉब अपॉर्चुनिटीज उनके लिए की जा सकती हैं, बट दे विल नॉट बी इन द जॉब फॉर लॉन्ग टाइम. जॉइंट फैमिली सिस्टम एक अच्छा सिस्टम था जिसमें everyone was being cared for, because my son doesn't listen to me but he listens to my dad because both are a common enemy. So वो कल्चर मेरे ख्याल जो मिस कर रहे हैं उससे भी थोड़ी दिक्कतें बुजुर्गों के लिए भी हैं, बच्चों के लिए भी हैं. होम केयर के लिए कोई पैरामीटर्स नहीं है, वो डेवलप होने चाहिए. हर ऑर्गेनाइजेशन अपना तरीका करते हैं. वी हैव डेवलप्ड ओन कुछ पैरामीटर्स हैं इंटरनेशनल, हम उसको भी करते हैं, बट नेशनल लेवल पे ऐसा कोई रूल नहीं है. यूके में सिस्टम है जहाँ होम केयर भी है. वहाँ लोगों को परेशानी ये है कि हम अपना डॉक्टर नहीं चुन सकते हैं. इंडिया में जो पैसे वाले लोग हैं वो सुबह अपोलो में दिखाते हैं, शाम को राजीव गांधी में दिखा देते हैं. तो ये भी एक हर कंट्री में अपनी दिक्कत है. बुजुर्गों में एक इशू और है, वो थोड़ा कम खाते हैं, कम सोते हैं, कम एक्सरसाइज करते हैं, वो सर्कल में फंस जाते हैं. उससे वो कमज़ोर होते हैं, मसल वीक होती है, गिर जाते हैं. गिरने से हिप फ्रैक्चर हुआ तो जान जा सकती है. कोई कंपनी नहीं है तो डिप्रेशन प्रोन भी हैं, स्ट्रोक प्रोन भी हैं. कुछ लोगों का ब्लड प्रेशर तब चेक होता है जब उनको स्ट्रोक होता है, और मेजॉरिटी में स्ट्रोक हम ठीक नहीं कर पाते हैं. दे आर डिसेबल्ड फॉर लाइफ. मेंटल इशू भी हैं, डिप्रेशन भी काफ़ी कॉमन है, कंपनी नहीं है. और 60 साल में रिटायर हो गए और जीना 85 साल तक है. वो 25 साल वाला पीरियड बड़ा, कई बार सुन नहीं पाते हैं. विजन भी प्रॉब्लम है. विजन वाली प्रॉब्लम बहुत सारे एल्डर्स की ठीक की जा सकती है. एंड गवर्नमेंट्स, all governments will have free facility, makes a big difference. Dentures are a problem, many of them die of cardiac issues. सांस का फूलना in cities like Delhi is so common that और फिर बुजुर्गों के साथ दिक्कत है कि वो इनहेलर्स को यूज़ नहीं कर पाते हैं ठीक से, और जब वो स्पेसर या नेबुलाइजर पे जाते हैं तो उसकी कॉस्ट भी बढ़ जाती है. I daily see patients in my OPD where बोलते हैं सांस फूल रहा है और हम ये अफोर्ड नहीं कर सकते हैं. और ये मेडिसिन हमारे कैनसपोर्ट वाली लिस्ट में भी नहीं. हम लिखते हैं विद ए लॉट ऑफ पेन इन द हार्ट. अगर आपने स्किन छोटे बच्चे की देखी हो और बुजुर्ग की देखी हो, बुजुर्ग की पार्चमेंट जैसी होती है। कई हाउस होल्ड रेमेडीज हैं जो अच्छा काम कर सकते हैं। फ्यू ड्रॉप्स ऑफ ग्लिसरीन with a spoon of water will be an excellent moisturizer. Please don't prescribe moisturizer for old people. Poverty is an issue. And of course isolation. हमारे कैंसर पेशेंट भी ज़्यादा एल्डरली होते हैं, उनके साथ उनकी कोमॉर्बिडिटीज़ भी हैं। आप हैरान होंगे सुन के, कई बार हमारी कैंसर का पेशेंट कैंसर से ना मर के सांस की तकलीफ से मर जाता है। तो जब कैंसर टीम जाती है, हम ये भी ध्यान रखना है कि वो कोमॉर्बिडिटी भी है, उसका स्पाउस भी अगर एल्डरली है, कहीं वो ना मर जाए उससे पहले। ये चीज़ों का भी ध्यान रखने की ज़रूरत है। बिकॉज पैलिएटिव केयर इज पेशेंट फोकस्ड एंड फैमिली ओरिएंटेड, हमें इन चीज़ों का भी ध्यान रखना है। डायबिटीज़ भी एल्डरली में ज़्यादा कॉमन है। इंडिया इज़ अ डायबिटिक कैपिटल ऑफ द वर्ल्ड। एल्डरली में सिम्टम्स भी अलग होते हैं, जैसे ज़्यादा भूख लगना, ज़्यादा प्यास लगना, ये सिम्टम नहीं हो, गिर गए या कोई विजुअल सिम्टम हो गए या कोमा में चले गए, जब टेस्ट हुआ पता चला डायबिटीज़ है। फिर एक बुजुर्ग दवाइयाँ कई तरह की खा रहे होते हैं। मेरी प्रैक्टिस ये है, मैं उनको कहता हूँ जो दवाइयाँ खाते हैं वो सब एक प्लेट में रखिए, भर जाती है प्लेट वो। फिर पूछता हूँ वो भी पड़ी है कि सर वो भूल गया। मतलब पॉलीथेरेपी इतनी ज़्यादा होती है, लिवर वीक है, किडनी वीक है, उसके बाद इतनी मेडिकेशन खाना। और अगर अमीर फैमिली है तो फिर तो 2 प्लेट चाहिए होती हैं यूजली। और कई बार ना सेम मेडिकेशन के डिफरेंट फॉर्मुलेशंस होंगे। अपोलो गए तो उन्होंने कुछ भी और ब्रांड लिख दिया, राजीव गांधी गए तो जो मेडिसिन टॉक्सिक भी हो सकते हैं कई बार। क्या ओल्ड एज होम एक रास्ता है? आई हैव ए पर्सनल इंटरेस्ट इन सच फैसिलिटीज। इंडियन सेटअप में मुश्किल है, cost prohibitive, and there's a old age home in Faridabad where people pay through your nose. अगर हम अपने बुजुर्गों को घर में रख पाएँ और होम बेस्ड पैलिएटिव केयर कर पाएँ, नथिंग लाइक दैट। आई फोरसी दैट फ्यूचर कि मुझे शायद ऐसा मौका मिले तो विलेजेस में एक चीज़, उनका कल्चर थोड़ा ज़्यादा सपोर्टिव है। शहर में ना पड़ोसी को नहीं जानता है। मेरे पड़ोस में चोरी हुई, सारा सामान ले गए, वहाँ बंदा कॉफ़ी भी पी के गया। जब पुलिस नेक्स्ट डे पूछने, दे सेड हमें लगा घर शिफ्ट कर रहे होंगे। तो दिस इज व्हाट इज हैपनिंग इन सिटीज। फियर ऑफ डेथ हर वक्त रहता है बुजुर्ग लोगों को। और कई बारी जो लोग ज़्यादा बीमार रहते हैं वो स्पाउस की डेथ नहीं दूसरी की हो जाती है, तो उसको भी केटर करना है। और बुजुर्गों को एंड ऑफ लाइफ केयर में अगर आप हॉस्पिटल्स में एडमिट करें तो 2 जनरेशन को पॉवर्टी में पुश कर सकते हैं। इंडिया में वन ऑफ द पॉवर्टी रीजंस इज दिस इज इक्वेशन डन कि अगर आप होम केयर करें जैसे कैंसपोर्ट करता है, फ्री या कुछ हज़ारों में हो जाएगा, और वहाँ 10 लाख प्लस कैलकुलेशंस हैव डन बाय पीपल। जो लोग अपना घर या खेत बेच के ट्रीटमेंट कराते हैं उन सिकनेसेस के लिए जो ठीक नहीं हो सकती हैं, इट्स ए फ्यूटाइल इंटरवेंशन। इट इज़ नाइदर मेडिकली करेक्ट, नॉर सोशली करेक्ट, नॉर एथिकली करेक्ट। ऐसा होता है। और कॉर्पोरेट हॉस्पिटल्स आर वेरी हैप्पी टू डू इट, बट देयर सम गुड डॉक्टर्स हु टेल देम कि फ़ायदा नहीं है, इनको घर ले जाइए। कई बार हम खुद लोग अपने रिश्तेदार को मरने नहीं देना चाहते हैं। वी डोंट थिंक डेथ इज पार्ट ऑफ लाइफ। मर जाना फैमिली का फेलियर है और सिस्टम का फेलियर है। अगर कोई नेता इन्वॉल्व है वो कहे जी डॉक्टर साहब कुछ भी हो जाए, पैसा पानी की तरह भाजूंगा, मेरा पेशेंट नहीं मरना चाहिए. So they produce stress all around. एल्डर्स का कैंसर पेशेंट कुछ टाइम में मर जाते हैं हमारे सारे, लेकिन एल्डर्स कई बार बहुत लंबा जीते हैं. अगर मैं 90 साल जीऊँगा तो लाइकली है कि मेरा बेटा मुझे अब्यूज़ करे या उसकी वाइफ मुझे अब्यूज़ करे, क्योंकि लंबी केयर बड़ी मुश्किल है. हम बच्चों की तो केयर कर लेते हैं, अपने बुजुर्गों की केयर करनी भारी पड़ती है. हम बुजुर्गों की केयर करें जब तक. आज एक शख्स प्रोफेसर है, 65 साल का हो गया, अगले दिन रिटायर हो जाता है, वो यूजलेस नहीं होता है. He or she has still many years to contribute to the family, himself, family and the country also. अगर बुजुर्गों को अच्छी पैलेटिव केयर दी जाए, उनको यूजफुल बनाए रखा जा सकता है ताकि वो बर्डन ना बने. जब भी हम जाते हैं, पेशेंट अगर एल्डरली है, उसका स्पाउस भी एल्डरली है, कोशिश, पेशेंट फोकस तो है ही, लेकिन हिडन पेशेंट पर भी फोकस होना चाहिए. आई थिंक देन जो आपकी सेवाएं दे रहे हैं वो भी खुश होते हैं, और हम जैसे लोगों का तो ईश्वर से कनेक्शन हो जाता है. Any questions or comments I would love to answer? Thank you, sir.
Thank you, Dr. Mohan. I think from your experience, we really got a lot of, a connection with the presentation you made. And I just want to raise some points which I think are very critical from their paper. One is that I think you cannot understand the needs of home-based care if you don't see it in relation to policies and the framing of the landscape of provisioning. And I think your focus on looking at public sector policies is very critical, because no matter in whichever country you see in the world, you cannot provide universal equitous services if you rely on the private sector. And I think this came out very strongly. And a very important aspect that got highlighted was the fragmented landscape. And this fragmented landscape of having multiple actors, you have the Ministry of Social Justice, you have different ministries trying to do inputs into the needs of older persons, but not really having any conversation among them. And I remember when we did a study for the Asia Pacific Observatory of WHO, and we were interviewing people in the central government, actually in terms of power relations, the Department of Social Justice neither gets the funding, unlike health. So, in terms of hierarchy of these various ministries itself, you see an unequal landscape. And I think if you start looking at aging as a public health concern, the model you came out with, which is the continuum of care, the functional social, the medical, you cannot separate them. This particular condition demands for an inter kind of relationship, interdisciplinary kind of an understanding. I think it also becomes what is called as a complex or a wicked problem. Wicked problem is a very social science term. It's a wicked problem because it doesn't have simple solutions. And I think part of this has come out very vividly in your work and in what Dr. Mohan has commented on, because it actually you know, it's very complex. You just don't have the physical problem. You also have the emotional, you have the social, you have the economic. And one of the things which I found very interesting in your paper is this whole angle of pensions. Because if you look at many of the social science studies, you find financial insecurity as a major source of stress as you age. And even if you are a central government employee, the pension you earn is half of what your take home pay was. So immediately, when the needs are very great, you are actually having a financial insecurity. And the proportion of population that's actually covered by pensions is very small. So the dependence on the family really, really increases. So when we say you should, age with independence, dignity, and a good quality of life, if you don't have these in place, I think it's a real issue. And of course, multiple morbidities that you spoke about is a huge challenge for the health system itself. But all non-communicable diseases require continuum of care. Even, there was a study done in Chennai where it shows that an elderly woman who is suffering from diabetes, she has to have regular monitoring of her blood sugar, but she's not able to because the health services very often don't reach out to her. And I think the aspect that you brought about of feminization of aging is a serious concern, changing family structures, and at both ends of the social gradient. That is, you have working class migrating, that in form of labor. You also have upper class migration. Children who have left to go and settle in other parts of the world. And in fact, that fuels this private sector. My own study in Coimbatore, for example, clearly shows the NRI link between, children actually remitting some money, but also elders living alone, and then this rise of what you described as private, what they called supported communities for older persons. And the South is a hub for it now. And that is where, like you rightly said, there is a social gradient in the access to these services, whether it is so-called highly trained quality, in quotes, like Portia and other agencies, but even there are these other problems that you spoke about. I think this question of multiple actors and agencies in planning for older persons' care in the way it is at present is a real problem. And when you spoke about China and Japan and even South Korea, what's very interesting, we did some work in Shanghai. We were astounded by the role of local governments. You see, we are only talking about state and center. Kerala has local self-government, but it is largely in the rural area through the panchayats. And one of the things we found in our own study is that it is really the poorer who access these services. There is a status issue involved with the middle and the upper middle classes. So, people are making their own arrangements for care. And in China, Japan, and South Korea, all innovations have happened at the local level. So it is not one size fits all. So maybe we need to, I don't know, I think maybe a logical move out of this group at some point would be to actually look at the activities of agencies like CanSupport, maybe HelpAge India, NGOs that are trying to raise these issues of availability of resources, of certification, of training people, because I think this would really be important to make the point that you cannot have something that is constantly centrally directed, that there has to be an acknowledgement of need for innovations. How do you use those innovations? Can you upscale those innovations? And I think that becomes a very, very important aspect. And I just want to, the last point I want to make is, that we don't need a very doctor-centric approach at all. And I think reviving this idea of a family physician is a good idea. But we don't have many takers for the family physician idea. So, neither for the geriatric physician. So, I think somewhere we need to maybe deliberate and think about some of these issues. I now leave the floor open for a discussion, but if you would like to add something before that, I request you to do that.
Nothing much really, but the point about local governments playing their role, the municipalities in the cities and the local governments in the rural areas, that I think is very important, because what I found interesting in my reading was the Japan example that Sonali was referring to, which is done by the local government, and there is a cafe which is run by older people, and everybody and anybody can come there. They are fed there, there is food available there. There are private companies that set up shop at which people can access services at subsidized rates. They also organize for intergenerational interaction of the community with people, younger people. So within the neighborhood, they are taken care of. There's a social club also where they can go out. So that kind of, and that can be done only at a very local level, which, I mean, I think it's not very difficult to do. It's only the intent has to be there, that thought of, we need to start talking more about it in the public domain, and demanding this from our municipal corporations, from the local self-governments. This may not even need a whole lot of resources. It's more about planning and reorganizing the resources that one has. So that's something very doable that I see amongst all the other things that we have spoken about.
Any questions? Comments?
Hi, my name is Ishtikar. So thank you for the intense and insightful presentation. But I would like to thank to whole discussion, because they have very good insight, and particularly I am very impressed with Dr. Mohan and Baru ma'am. Sorry for my voice. So because as also Dr. Mohan mentioned about that, there is some intergenerational gap as well, because you don't understand the children, just like he mentioned, after some age the children is started to arguing, abusing, and all these things, they fed up with all. But between this, there is a in all home care, just like you mentioned about the functional, social, and medical. But as Baru ma'am said, it's very complex. But there is a between the psychological care as well, because in all these three intervention, if you will see, there is a psychological problems with the caregivers, as Dr. Mohan also mentioned about the caregivers' mental health, stress, how they are managing things. And about the home care, as you mentioned, it is also very problematic, because as you mentioned about the migration and urbanization, because of the nuclear family emerging there. But within the nuclear family, because earlier older people had some assets, so so it's kind of force, it was kind of compulsion to take care of your elders. But these days we don't have that assets, because you are migrating, and nuclear family are creating and developing, so growing so much. So now we don't have that kind of burden, therefore we don't care much about our elders. And about the home care, if you will see, it's about just like she also mentioned about the feminizing all the older age. But there is a not only cultural, because if you will see the home-based care, there is not only just sensitivity of the cultural, religious as well. Because I remember the Kavita, Dr. Kavita, so once we were discussing about that, you can afford care service provider, but problem is that about the understanding, as you mentioned while presenting that, about the understanding, that's like coming from the south and now from north to south, if you are going to providing for the as a livelihood, because you are seeing as a livelihood instead of taking of care of the elder. So that is also kind of training and kind of gap between the service provider and service giver. So that is also kind of, so it is just my observation and insight from my own study and observation during the LASIDAT project also. Yes, thank you.
Thank you, Ishtikar.
Thank you very much. Thank you very much for this presentation to Pallavi, Sonali, and of course Dr. Mohan. Uh, there are so many observations and remarks, valuable remarks in what you have said. But I'll just confine myself to one or two questions. One thing which struck me was that whilst there is a lot of unemployment amongst young people, there is simultaneously a scarcity of people going for care work. So obviously they don't want to go for care work. They would like to, say, apply for a railway job even if the ratio is 1 lakh to 1 vacancy. And now I was trying to see why these jobs are so undesirable. Apart from the conditions you mentioned of insecurity, treatment, and maybe not very good pay, I think one factor is that the difference between service and being a servant is not, is blurred over, both from the provider's point of view and the receiver's point of view. You mentioned they are exploited, asked to do cooking work and also. So I wonder whether there is any training at the civics class level in schools and so on about the concept of service. Like Gandhiji used to talk about service, not being a servant necessarily. So that these jobs are not seen as anything undesirable or demeaning. You mentioned status. You see, this is one thing that leaps out in the Indian system. So, and this probably will be a barrier to many people who are capable of doing this work. Because my second question is, as far as training is concerned, isn't it a fact that the basic skill, if it is a skill at all, maybe it is an attribute, required is an attitude of kindness, patience, and compassion. I think the physical skills are not that great, at least at the non-specialist level, like non-medical, even paramedical requires training, but otherwise you don't require that much. Now, are those innate in personality, in which case the skill then comes in selection of those people. If it is, I doubt whether you can train compassion. Maybe you can, I don't know. But perhaps some form of sensitization. You mentioned the grandchild in that example. The grandchild noticed how the care is being given and what is the improvement. That grandchild will grow up to be a good carer. So in our schools and so on, I don't know whether these are given any importance, because everybody has a parent and a grandparent. So I'll stop here. I'll just throw these ideas.
Go ahead.
One small point. The way Sir has underlined the youngsters who are unemployed, they should be put for the service. I think we can have elderly people like 60 plus. They are themselves going to become 90, or they themselves can give care to elderly, 60 to 70, 70 to 80 or 80 to 90. This type of hierarchy can be there. So the elderly people can take care of elderly one. I think this can work.
Just to go back to your point, I frankly don't know what children are taught in civics these days, what is happening on that. But the point about workforce and why people don't want to go get into it. So in one of our earlier discussions around the same topic, this thing about dignity of work had come about as a very big issue, that if we have to have care workers and good quality care workers, we need to promote this and build this as a dignified work and not something to be looked down upon, which is the main concern. People don't want to get into it because at the end of the day, it's not very nice work. You may be supporting person with the day-to-day activities, which is not really pleasant or nice. So how do we make this a more dignified work as a profession in which you can have growth? Because there are a lot of people who are also migrating abroad for these services. And somehow going there, people are still okay doing it, maybe because it pays more, maybe it's a status symbol that you're working abroad. But so we will have to work around into making this as about dignity of work, and that it is not something that is not to be, you don't want to do it. And also look at career progression, because nobody will want to keep doing the same thing over and over again, whether educated or not educated. So what are the areas in which people can then further specialize? And this dignity will come from multiple factors, how respectfully they are treated by everybody, their employer, the family in which they are working. So all of that will also contribute to. And there are some organizations, while we were doing our research, whom we spoke to, they said this thing about selection of workers, that because as we mentioned, attitude and aptitude, these are two important things, and as you rightly said, skills can be taught. But that kind of attitude, either it has to be inherent and you bring it out, or maybe over time somebody develops it, or you really have to have the skills to identify people with such aptitude. So some organizations do take, say, 100 people, and then they said that about 20 remain by the end of it. And we test them on different skills, and we tell them what this is about. So like we were doing this interview with Indian Red Cross person, and they said many people join, come in for training, and when they realize what kind of work they have to do, then they leave. They don't want to do it. It's also about providing services at home. Doing the same thing in hospital is not considered so bad. It is okay, we are working in a hospital. But to go to somebody's home and provide these services, and then to go to different homes and at different points of time, 1 week here, 1 week there, especially for women care workers, that was also a concern. So these are issues, and unless we make it about dignity, that just as a child would do for parent, and it a lot depends, I think, on the way the family treats a care worker once they are at home.
I'll just add, sorry ma'am, to this as well. So these points actually came quite a major fact when we were talking to some of the organizations, some of the training institutions as well. So one of them said, because they had realized they take up 100 people and just 20 remain by the end of it, the attrition is so much, they started doing the counseling first with the intake of the enrollees, that this is the sort of work is going to be. So you only join us if you think you can continue with this sort of work. So that pre-counseling was important, so that the attrition, so as an organization, if you're also putting so much money, that remains. The second part was the eligibility. With the Red Cross, the program was good, the training was home care provider, but their eligibility for this was somebody coming from the poor or from a poor household level. So from the beginning itself, you're sort of, de-dignified the work, because you're saying that this group of people will come and join this course. So at the beginning itself, the course has got some reputation to it. So that is something maybe going forward when the institutions are training, that has to be universalized to everyone. There's one example, like some states have been doing, I think Japan only example, where they're taking kids from the northeastern to Japan. They'll do the same work. They're only taking because their ethnicity matches. So they'll do the home care work there as well. People are easily going, they're doing that migration because वहाँ पे थोड़ा dignity है, यहाँ पे वो same करेंगे वो नहीं है. So that also varies a little bit with how we see as the work. So
yeah, I'd like to build on what you said. There's a company which is actually training and taking staff from here to Japan, and they're advertising it. Yes. That you're going to be trained, then you're going to get this opportunity to be in Japan, you're going to be paid well, because the Japanese rules will, in a sense, apply to them. So I think there is another layer to this whole thing about, like you rightly said, care workers being trained, but care workers then going away, even to Canada, UK, Western Europe. There is now an opening for care workers migration. Earlier we had the nurse migration. Earlier, first the doctors, then the nurses, and now the care workers. And even companies in UK who are trying to broker this passage. of
Like we used to have nursing bureaus.
Sir, caring is a stressful job.
yeah, it is.
And not only for low paid workers, in our cancer experience has been, we tell doctors to go on their own in the field and make up their mind, will they fit in?
No.
कुछ लोग सर 6 घंटे बाद छोड़ जाते हैं. Work is very good, but it's not my cup of tea. Some people leave after 1 week, and the guys who stay for 1 year, you push them, they will not leave. They get addicted to this work. So it's not everybody's cup of tea. My Singapore experience was, younger nurses don't opt for home care. Experienced one, they do, knowing it's a difficult job, but it's satisfying.
Yes, yes.
Can I add one story?
Like sir told,
Yeah.
among elder people do help. The place I stay, there's an old man, Mr. Kohli. He got which card, PMJ card for all seniors in that area. And the one who couldn't walk, he arranged that they come in a wheelchair and their card is made. So elderly can do help.
Sir, I want to add one story. Few years back, UN Secretary General present, he came to Delhi to a public lecture. So he said, I was the Prime Minister of my country. A migration issue was a big issue from Pakistan, India, Philippines. People used to go. Then he said, I am the Prime Minister. I can't take care of my parents. Somebody migrating from third world country and take care of. If there is no migration, our elder people will die. So migration is a big issue. We have to promote this way also. He said, thank you.
I think we've had a good discussion. If there are no further questions, I'd like to bring this session to a close. Thank you very much. And this program was also live streamed, so I hope there were people on the live stream also watching it. And thank you to the technical staff here and to all the IIC organizers for this opportunity. And we are hoping this will become an area of interest that more and more people would sort of engage with. And thank you very much.